Hi everyone. So in this lecture I'm going to be talking about coronary artery disease and how it relates to ischemia as well as infarction or death of the myocardial tissue. Then I'm going to discuss the clinical aspects of this disease in terms of its signs and symptoms, what you would find on a physical exam, and the diagnosis, the workup, and then a general overview of the treatment. Okay, so to begin our discussion about coronary artery disease, we're going to talk about atherosclerosis, one of the most common causes for coronary artery disease. So this primarily occurs in mid to large-sized arteries, and you'll primarily find them at junction points, so where they're branching. So some of the common places I've actually listed for you here, such as the abdominal aorta, where it becomes the iliac arteries, the proximal coronary arteries, and the carotid bifurcation. Carotid bifurcation, remember, is in the neck towards the angle of the jaw there. And the proximal coronary arteries, those are, if you recall, the larger coronary arteries that are located in the epicardium, or the outermost layer of the heart, and then they branch into smaller arterioles as it makes its way deeper into the tissue towards the endocardium, which is the innermost layer. Okay. Now, the process of actually forming an atherosclerotic plaque or an atheroma really involves these four main steps, which I bulleted for you here. You're going to have lipid accumulation in the subendocardium, okay, the subendocardial space there. Now remember, the endocardium, which is the innermost layer of the heart, is continuous with the endothelium, which is the innermost layer of the arteries. Remembering that with the artery you have several layers, just like you do with the heart. Okay, you have the intima, which is the endothelial layer. Okay, then you have the media, then you have the externa. So you have these three layers. Remember, the media has mostly the muscles and the connective tissues, like the smooth muscle and so on, and collagen and elastic fibers. And so lipids going to accumulate in the subendothelial or subendocardial space. Okay. And then when that occurs, you have inflammation, and the inflammatory reaction can release intermediates like interleukins and cytokines that can actually create a sort of positive feedback loop that will in part stimulate the lipids that are there, but also recruit white blood cells to actually aggregate at the site where the lipid is accumulating. And then the white blood cells will aggregate there. And when they aggregate, they'll also release more intermediates, and those intermediates can actually stimulate the smooth muscle in the media to proliferate. And so it can start to grow from the lipid accumulation as well as the smooth muscle proliferation. And so we'll talk a bit about those steps on the next slide. But as the atheroma enlarges, the problem is this: if it enlarges, it grows. It can grow outward. It can grow out into the wall, like the media, towards the externa, but it can only grow so far in that direction. But then it'll start to grow inward. And as it grows inward, it reduces the lumen through which the blood has to flow. This increases resistance, and in some cases, it can be very significant resistance. And the problem is, if it occurs in, say, the coronaries, it's increasing resistance to blood flow that the heart requires. And so that's when you start to see symptoms of pain and so on, something we call angina in the heart. It can reduce blood flow to the brain if it's happening in the carotids, and that would lead to maybe ischemia or a stroke, for example. Ultimately, one of the biggest dangers is not only that the fact that it reduces the lumen and then increases resistance to blood flow, it can actually weaken the wall, and it can weaken the endothelial lining, and it can make the healthy endothelium behave abnormally or respond abnormally. So we have to talk, I'll talk about what the endothelium is important for in a separate slide. But the idea is this, that if it ruptures that endothelium, then what you can have is a sudden hemostasis occurring. And it's a higher risk for rupturing because it grows out and pushes the endothelium out into the lumen and exposes that underlying collagen. And once you do that, you can activate platelets in the coagulation cascade, and you can actually form a thrombus very quickly right there on the spot. And that can completely occlude the vessel, or at least substantially occlude it more, leading to complete shutoff of blood flow downstream. And this can lead to sudden onsets of strokes and heart attacks and so on. Okay, so let's talk in brief about the mechanism of plaque formation. Okay, the primary instigator for plaque formation is having an injured endothelium. This comes about based on some of the risk factors we've heard of when it comes to atherosclerosis, which is smoking, diabetes, hypertension, dyslipidemia, and so on. And these play a role in injuring our healthy endothelium, and the healthy endothelium plays a role in maintaining our homeostasis. So we can lose homeostasis, and what ends up happening is the endothelium loses the ability to appropriately exclude stuff from our blood plasma and becomes more permeable. So for example, if you're a smoker and these oxygen radicals that are produced can activate the endothelium, the endothelium can then release cytokines and interleukins, which can actually recruit white blood cells. And by activating the endothelium become more permeable to allow the white blood cells into the subendothelial space, so that under normal circumstances it would it would attack an infection there, or some sort of an organism that may be present. But in this case, it's opening up, making the endothelium more permeable, and things like LDL can actually go in the subendothelial space and bind to the extracellular matrix proteins like the proteoglycans. And this is exactly what happens. The LDL can now go through the endothelial barrier, bind to the proteoglycans, they become oxidized. This induces the release of more cytokines from the endothelium, which recruits these white blood cells, particularly monocytes from the bloodstream, as well as T lymphocytes. These monocytes, as soon as they make their way into the subendothelial space, become macrophages. Once they're macrophages, they're going to gobble up all this oxidized LDL, and they can actually ingest a lot of this oxidized LDL to the point where they become so large that we call them foam cells, because they look kind of foamy as they're ingested. Now they can continue to ingest, and what happens is they may even burst, releasing some of their intracellular material, which can actually induce further cytokine proliferation and release from the endothelium. Now, when enough of these macrophages get in there and gobble up all these LDLs, they can form what we call a fatty streak, okay, which is really sort of the beginning process of an atherosclerotic plaque. Now, once the macrophages are gobbling them up, creating this fatty streak, they can also induce the media, the smooth muscle cells in the media, to proliferate and to migrate to that subendothelial space. When smooth muscles make their way into that subendothelial space, they're going to release more proteoglycans and collagen. So just to point out that in this case that the smooth muscle cells actually play a role not only in contraction of the muscles in the arteries, but also in the production of extracellular matrix proteins like proteoglycans and collagen. So what happens is the macrophages release platelet-derived growth factor, which stimulates smooth muscles to migrate to that area, proliferate, and release these extracellular matrix proteins. More proteoglycans means more LDL can bind to it, so that's sort of a positive feedback, which can become oxidized and produce more cytokines, etc. And it's also going to lay down a lot of collagen. And so this is where these fatty streak can become more fibrous as more collagen is getting laid down. And so this is really the formation of our plaque. And it can start to enlarge because as the smooth muscle surrounds this fatty streak and these enlarging foam cells, the foam cells can burst and die, and you have necrotic tissue at its core. And what can happen is you end up having this balance between the breakdown of this collagen and the rebuilding, and it can continue to grow and push outward and ultimately impinge on the lumen. And what they found is that over time you get these micro breaks that can occur, where the collagen underneath the endothelium gets exposed to the blood and activates platelets and activates the clotting cascade, and you can get little microclots that form, and this can cause expansion and further expansion of this plaque. And so this is going to be sort of the underlying process that's occurring for most of these patients with these risk factors that ultimately lead from anything from stable angina, which is just a fixed narrowing, all the way up to unstable angina and a STEMI, or an ST elevation MI, which is a sudden rupture of the plaque, which causes a thrombus to form very quickly. So the risk factors, I mentioned some of them already. Dyslipidemia. It would make sense, I mean, if you have a more permeable endothelium due to its being damaged, if you're high in LDLs, the LDLs are the ones that can get in there and bind to the proteoglycans and oxidize. Okay, so higher concentrations means higher risk. Hypertension can cause stress along the endothelial wall, which can cause actual mechanical separation. But adaptation over time means that smooth muscle cells will proliferate due to the high pressures and release more proteoglycans, which means more proteoglycans for binding to LDLs. Smoking, diabetes. Diabetes is interesting because and it's probably the worst of all the risk factors would be diabetes, hypertension being the most common, because all the glucose can actually glycosylate substances in the blood non-enzymatically. And by doing so, that can then become antigenic and actually induce inflammation, which can cause some of the problem that we've been talking about. Obesity, advancing age, inactivity, poor diet, all the ones I've listed here. C-reactive protein is not a risk factor, but in this case, I've listed it here as an inflammatory marker. Okay, it's not specific to atherosclerosis, but it does correlate with an increased risk. So if somebody has atherosclerosis and a high C-reactive protein, means there's a lot of inflammation, which puts them at a higher risk category. In terms of prevention, some of it's very basic. Exercise to lose weight and so on. Diet with antioxidants to help reduce those radical formations. Statins, right, to reduce cholesterol levels and LDL levels. Antihypertensive, glucose controls for diabetics and so on. Okay, so now here's where we kind of get into one of the core ideas behind this entire lecture, which again has to do with really talking about stable angina, the progression from stable angina all the way to a myocardial infarction. And the whole process comes down to this basic concept of supply and demand. Now the concept is basic. It doesn't mean the physiology is always that basic, okay? But it's about supply and demand. So what that means is, over here, which I have this little cartoon for you guys, is we have myocardial oxygen supply and then the myocardial oxygen demand. And you can see there's kind of this balance point between the two, meaning that as at rest, we get enough blood flow and enough oxygen that's being supplied on a normal basis for the muscles to work appropriately and for the metabolism that's required. If for some reason they have to metabolize more, say the heart rate goes up, for example, all right, so there's more metabolism, it requires a higher supply of oxygen. And so there, under normal circumstances, there's an appropriate adjustment being made for that, okay? So when it comes to the oxygen supply, that really is about oxygen dissolved in the blood. Okay, so that's what oxygen content is referring to right here. So in terms of oxygen supply, oxygen content is what's dissolved in the plasma and what's bound to hemoglobin. So anything that would affect oxygen content would be something like pulmonary disease, where you're not getting good gas exchange, or you have anemia, for example, low hemoglobin. That would affect the content. Otherwise, the content doesn't really change all that much. But there's an important point to make here, which is under normal resting conditions, okay, the heart actually extracts 75% of the oxygen from the hemoglobin under resting conditions, during its normal metabolism, 75%. Now, in physiology, we talked about how overall the body primarily just extracts about 25%. So the heart extracts far more under resting conditions, which means there's not a whole lot left for it to actually extract from, okay? So that needs to be maintained, but more importantly, assuming we don't have a pulmonary disease or an anemia that can cause a drop in our content, blood flow becomes very important. So what happens is the heart, since it extracts most of the oxygen under resting conditions, if it's going to exert itself, let's say through an increase in heart rate, it has to be able to increase blood flow. So it really relies on flow. This is where having coronary artery disease becomes problematic, and that's what we're going to get more into. Okay, so we'll talk about that on a separate slide in terms of how the flow is adjusted and so on. Now, in terms of the demand, what puts a demand on the heart to demand more oxygen? Well, one I've already talked about, heart rate. Hopefully that seems obvious. Contractility, right? The heart has to contract. That requires more energy. Okay, but one that people tend to forget here would be wall stress. And wall stress is actually a tangential force along the inner line, or along the walls of the ventricles in the atria. And so it's a tangential force. It runs parallel to the muscle tissue. And really what's happening here is if I have my fists are, say, two different muscle cells, they're connected to each other, and they would pull apart. Every time they're contracting, they're going to be pulling on each other. And that creates stress. All right, that can create a wall stress. And so that actually requires energy to maintain the fact that they are able to stay connected to one another under these various stresses. But there are certain things that can cause undue stress on the heart, like, for example, we talked about in the heart failure, having volume overload. If I fill up the ventricles and I really stretch them out, that puts a lot of wall stress on those ventricles, okay, and on the atria as well. And that requires more energy for the wall, okay? So that's sort of the basic idea of wall stress, all right? It's basically keeping muscle cells connected to each other under that sort of duress. The compensation for that is to thicken the wall. So the thicker the wall becomes, the more it distributes that force, and so then the stress goes down. So that's when you start to see hypertrophy acting as a compensatory mechanism for wall stress. So that's the idea. So for example, increase in volume causes more wall stress, increase in heart rate, increase in contractility. These would all put more demand. Now, the reason this slide is so important and this basic concept is so important is that this is really also going to be how we approach treating the patient. So just a little foreshadowing, because I will talk about the treatments specifically a little bit later. Take heart rate, for example. If the heart rate goes up, but the supply is lacking, okay? Say poor perfusion, and the heart rate's gone up, and it's requiring more, but it's not getting it. We want to reduce the heart rate. So medications that reduce heart rate, reduce the demand, so that so we don't end up with this problem, okay? A beta blocker can reduce that. Right? It can also reduce contractility. So they're going to reduce the demand for the supply. And that kind of helps offset the problem here. Okay? So that's what we're aiming for, is taking a look at this relationship between these. Okay? So we'll get into that more when I talk about that as medications more specifically. Now the oxygen supply, which is the other side of it, which I kind of mentioned already, the oxygen content. Okay? But the perfusion. Perfusion is something that the heart really relies on. It has to be able to adjust moment to moment, okay? Because again, the heart rates are changing constantly, contractility is changing based on its demand and so on. So when it comes to perfusion, you have to maintain a good perfusion pressure. And I just want to remind you guys of this formula, all right? So flow, we draw it up here. Flow is equal to delta P over R. Some of you may know F. Instead of saying F for flow, let's say Q, for example. But F, all right, the flow equals the change in pressure over the resistance. This is Ohm's law, okay? And basically what this means right here, this delta P means that change in pressure. There has to be a difference in pressure. And so where that pressure is going to be highest is where blood is entering the coronaries. So hopefully that makes sense. And then as it moves more distally through the coronaries, pressures will start to drop as it goes along. So it would be highest at the entrance to the coronary. If you recall, during the cardiac cycle, coronary blood flow is increased during diastole, not systole. Because during systole, when it's contracted, all that muscle contracts, it really kind of pinches all those smaller blood vessels closed. So we don't get good blood flow because the pressure is too high, the resistance is too great. But when it relaxes, as it relaxes, blood flow can resume. So blood flow through the coronary arteries occurs during diastole. So if you have a blood pressure of 120 over 80, let's say, the blood pressure, or the pressure that's going to be perfusing at the beginning of that coronary flow, is going to be 80. That's the diastolic pressure. The diastolic pressure, remember, that's the pressure that's going to be perfusing into the coronaries now. All right, 120 is the systole. We don't get perfusion in the coronaries during systole, but diastole. So a typical average is going to be about 80 millimeters of mercury going into the coronaries, and of course it would get lower and lower as it makes its way through the coronaries. So this is what we need perfusion pressure for. The reason I bring that up is if somebody has a blood pressure, they become hypotensive, and their diastolic is, say, 60 or less than 60 millimeters of mercury, that may not be enough pressure during diastole to actually perfuse the coronaries adequately. Even if they have totally healthy coronary arteries, if for some other reason they're hypotensive, then they may not perfuse and they could have ischemia from that. Now, I've kind of already mentioned some of this already, but with vascular resistance, external forces What I mean by external forces is the compression during systole and then the relaxation during diastole to allow blood flow. There will be other factors within the tissue to influence that blood flow. So for example, you have something that's metabolic, endothelial, and neural. So these are all combinations of ways to affect coronary resistance. Reminding you guys that with resistance, which is R, right, that's our denominator down there, as resistance goes up, flow goes down. As resistance goes down, flow goes up. Okay, so they're inversely proportional to each other. So that means if the blood vessel constricts, there's less flow. If it dilates, there's more flow. Metabolic causes this. If there's an increase in metabolism of the tissue, because it's working hard, like during heart rate, an increase in heart rate, for example, all right, it can release something like adenosine, or not release so much as produce more and more adenosine as the breakdown from ATP to ADP, AMP, and then adenosine. So it's a breakdown product of metabolism that can actually cause vasodilation. It's a very potent vasodilator. And so that locally stimulates vasodilation to increase flow to those areas that require it. The endothelium itself, and so this cartoon right here is actually showing you a healthy endothelium. And if you guys recall, a healthy endothelium maintains homeostasis. Damaged endothelium does not, and that's where the risk comes in with atherosclerosis. All right. Now, under normal circumstances, the endothelium, in response to metabolizing tissue, can actually release things like nitric oxide and prostacyclin, which can locally act on the smooth muscle that it's nearby and cause it to relax. This one over here is endothelial-derived hyperpolarizing factor, which is just another factor that can cause relaxation. So there's multiple ways in which the endothelium can communicate with the smooth muscle. And it'll be in response to certain vasodilators that are released due to this higher stress situation. And it will cause relaxation, okay, and vasodilation. Endothelium, or endothelin, excuse me, is another mediator from the endothelium that can cause contraction. So a healthy endothelium responds appropriately to relaxation or constriction depending on what the situation calls for, okay? And which of course, specifically speaking, is induced by, certain dependent vasodilators and vasoconstrictors in the blood or in the tissue. And finally, they're also innervated. They have alpha and beta receptors, which means they can vasoconstrict and vasodilate appropriately to allow an increase in flow or decrease, reminding you that beta blockers, beta adrenergic receptors cause vasodilation or smooth muscle relaxation, and alpha receptors of the alpha adrenergics cause vasoconstriction. And so we have all these different mediators that help under normal circumstances to maintain appropriate flow. And under circumstances of, say, exercising, where you have an increase in sympathetic output, you're going to get primarily coronary vasodilation to allow as much flow as possible, because as you recall, it's already extracting almost maximally the amount of oxygen it possibly can under resting conditions, which means we just have to increase that flow as much as possible. So we're really reliant on that. And we're also reliant on this diastolic blood pressure to give us the perfusing pressure that's appropriate. This slide here really is just it's a gimme here. This is wall stress, heart rate, and contractility, which I actually already spoke about. Pathophysiology here, so we're going to talk a little bit about that flow in a little more detail now as it pertains to atherosclerosis or stenosis of the vessel. So what we have here is both a combination of what we call fixed narrowing. So basically you have a atherosclerotic plaque that's growing, and it narrows the lumen, but it narrows it to a sort of in a fixed manner. Okay, because as it grows in a certain amount and stays there, and it's going to keep that lumen narrowed like that in a fixed way. Now, the additional component to this is the endothelium that is now near this plaque is not functioning normally. It's not maintaining normal homeostasis. Normal homeostasis for the endothelial cell means preventing coagulation, inappropriate coagulation, and platelet activation, vasodilating or vasoconstricting appropriately, okay, and acting as a permeability barrier. Once it loses its ability to do that, what ends up happening is it can vasoconstrict inappropriately, you can get clotting inappropriately, and it can allow more accumulation of LDLs and so on in that space, and that's problematic, okay? And we'll get more into that as we talk more about the sort of the clinical aspects of it. In terms of the fluid mechanics, it increases resistance because now you have not only a narrower diameter, but also depending on the length of it, the length plus the diameter are proportional to an increase in resistance. So primarily it's the proximal coronary arteries that are affected. So the distal arterioles are actually usually free of plaque. It's the proximal ones that are located in that epicardium. They're the ones that are at highest risk. And so what happens is if they start to become narrow, downstream of that towards the smaller arterioles, they're the ones that will end up lacking that blood flow or that perfusion due to those proximal larger coronary arteries. Okay, so what are the distal arterioles going to do in response to a decrease in flow if there's a stenotic valve in the proximal coronary artery? Well, what it's going to do is it's going to vasodilate in response to that to increase its flow downstream. Okay, so for example, if this is a blood vessel here, all right, I'm just going to draw the plaque, let's say right here, and this is in a proximal coronary vessel. And so down here would be the arteriole, let's say, distally, arteriole, so draw the whole thing out. This will be the proximal coronary up here. So blood flow is going in this direction. So now I have resistance because of that plaque. That means there's decreased flow towards the arteriole. So the arteriole is going to then vasodilate. It's going to open up to increase its flow. It's going to vasodilate. And that's going to help increase its flow downstream. So that's going to be an appropriate response to that. Okay? So that's what we mean by compensatory vasodilation by the arterioles. Now, if you look at this graph here, to understand the clinical significance of this, this is referring to the percent of diameter stenosis relative to the coronary blood flow. So this coronary blood flow, all right, these are standardized numbers. So what you have is, if this is our resting blood flow at 1, you can see here's our resting blood flow. Now, if we increase our activity, as you know, we can also increase our coronary blood flow through vasodilation, so on, increase perfusion. And so our maximum flow, all right, so we have resting and maximum. And you'll notice that's about 5 times the amount of the flow based on this chart right here. So it really can significantly increase blood flow via vasodilation and so on. Now, what this diameter stenosis is telling you is saying, all right, well, let's assume for a second we have a 25% stenosis. So that's saying, let's say that stenosis right there is 25%. How does it affect the resting flow? Well, it doesn't really affect it all that much. In fact, it's still flat. And if you look, it doesn't even affect the maximum flow, which means we have sort of cushion room, if you will. All right, a lot of flexibility in there, a lot of ability to vasodilate appropriately to still get the appropriate flow for to still get a maximum flow out of it. Now, what you'll notice is that once we get to the 40 to 80% range there, it's kind of a broad range. I kind of wish I had drawn it out a little bit clearer, but typically, and I'm going to give you some numbers here. I'm going to put 70% right there. We're going to say up to about 70%, you will have essentially normal resting flow, and you could probably still get maximum flow, even with 70% stenosis. Okay? Once you get above 70% stenosis, look what happens though. You have resting flow stays exactly the same. It's still flat. So it doesn't affect rest. So there may not be any symptoms at rest, but look what quickly happens after 70% to the maximum flow. This is where you have exertional angina. This is where the flow or the supply doesn't meet the demand, and you see it starts to drop off. And in fact, I'm going to draw 90% right about here. Once we get to 90%, look what happens at this point right here. Resting, not a problem, but you have basically no maximum flow. Your resting flow is your maximum flow. Any kind of exertion is going to cause some type of symptom. And then at that point, once you're above 90%, you have essentially a drop-off of even your resting. So this is where symptoms can occur even at rest, and obviously at 100%. And this 100% here, you have a complete drop-off of flow entirely, right? Because it's completely occluded. And this is an example of how one vessel would behave. Okay. So this, all comes down to, as I mentioned already, having a healthy endothelium, maintaining that homeostasis. And this is what this cartoon is showing you right here. All right, here's our endothelium. All this oxidative stress due to the risk factors I've already mentioned, like diabetes and hypertension and so on, causes that oxidative stress, causes abnormal endothelial function. All right, that reduces the availability of things like nitric oxide and prostacyclin. That means it doesn't vasoconstrict or vasodilate very well, which is important when you, especially when you want more supply. So it doesn't. So we end up with more vasoconstriction typically than vasodilation, and that's problematic to flow. Okay. Nitric oxide and prostacyclin, if you recall, are also necessary for inhibiting platelet activation. So if it's not as readily available now you can have platelet aggregation and thrombosis. So now we're at an increased risk for clots. Okay. Vascular smooth muscle cell proliferation, because it can actually stimulate them through all these cytokines and so on. Lipid deposition through all the things I talked about in the previous slides. Leukocyte adhesion and inflammation and so on. All the parts of the processes of atherosclerosis. So the consequences of ischemia. All right. This is, again, secondary to inadequate myocardial oxygenation, right? Inadequate supply and demand. The demand is up, the supply is lacking. And so what happens is you end up with an accumulation of metabolites, and these metabolites typically are supposed to induce good changes like vasodilation and so on. And since they're not getting washed away because of poor perfusion, they accumulate. Then you have a loss of ATP, so the muscles switch to anaerobic respiration. Okay, so you can have a buildup of lactate, serotonin, adenosine. These can locally actually stimulate pain receptors, and they'll travel back to the spinal cord through levels C7 or T4, so low cervical or high thoracic region, which is what causes the pain sensations and some of the feeling of pain in, say, the shoulder or the jaw, for example. The outcome of this really depends on how severe the ischemia was and what was the duration of it. Basically how large was of a coronary artery was occluded. Because if it's a very proximal artery that distributes to a large portion of the heart, or a large portion of, let's say, the left ventricle, like 2/3 of it, that's going to be pretty bad, all right? Because that could really affect its ability to function appropriately. And if it was transient, then maybe not such a big deal. But if it was prolonged, I mean, now you could risk tissue death, okay? And it may become irreversible. So that's what irreversible necrosis would be. Otherwise, if it's transient, you could have rapid and full recovery. But if you're in that sort of gray zone in between rapid recovery and prolonged to the point of death, where you have this prolonged ischemia without necrosis, what you can end up with is myocardium that ends up being either stunned or could even hibernate. Stunned just means that it was more of an acute scenario where it lacked enough flow, but it recovered quickly enough, not necessarily rapidly, but just quickly enough where it was able to get the flow in time to prevent it from dying. But then it takes a day or two or a little bit more for that muscle to recover back to its normal function again. Versus, say, hibernating myocardium. Hibernating myocardium just means that it's operating on a very low level chronically. Because the blood supply has been so low for so long, it has readjusted its sort of working baseline. And so now it doesn't contract as well or relax as well overall for a prolonged period of time. This tissue is also salvageable, and one of the main reasons we'll actually do a lot of imaging and so on and test to see if that tissue exists so that we can save it and have it hopefully recover. So in terms of the ischemic syndromes, we have stable angina, all right, unstable angina, which is part of the acute coronary syndromes, which I've labeled an ACS there, variant angina, otherwise known as Prinzmetal, and then silent ischemia. All right, so those are some of the basic ones. Now, if we take a look at this cartoon over here, you see in A, this is normal. We have normal lumen, healthy endothelial cells, which means they're doing their appropriate homeostatic mechanisms, okay? Now with stable angina, which is the first one I'm really going to be talking about in this lecture, all right, this, you can see here, this plaque, this is a fixed lumen narrowing. That's the fixed portion of it, the plaque that built up there. The endothelium that overlies that plaque is now going to be not functional in terms of its, or appropriately functional in terms of its homeostasis. So therefore, it be more prone to vasoconstriction, as well as increasing risk for clotting. Okay. because again, this is going to be endothelium that's releasing things like cytokines and interleukins, and it's more permeable and so on. And as you'll see, in many cases, these will tend to grow and it's sort of insidious. So you don't see this often in younger patients, but it would be more in middle age to the elderly who've had a prolonged period of time for this. Unstable angina. So, this is a continuation of stable angina into unstable. What's happened is, as I mentioned earlier, you could have a sudden rupture of that plaque. All right. And if it ruptures and opens up and the endothelium now exposes the collagen to the blood, you will then initiate a clotting cascade as well as the platelet aggregation. Depending on the size of that clot or the size of the rupture, really, you'll have different size clots that can form. And that's really the characteristic of any of the acute coronary syndromes, is this sudden clot formation. And that's really the highest risk. That's really the risk for them. So that's that thrombus formation. And then you also have on top of it the unopposed vasoconstriction due to that damaged endothelium. And that becomes problematic because even if the clot doesn't completely occlude the lumen, the inappropriate vasoconstriction can then pinch down on it and actually cause the occlusion. So that's very problematic. The variant, or the Prinz medal here, you could actually have completely patent lumen with no plaque per se, and the endothelium may or may not be more responsive. It depends. It's still uncertain. But what happens is you end up with these spasms, and the spasms cause severe constrictions, and they can be so intense it can actually almost completely occlude blood flow, where it can cause quite a lot of ischemia, and in between spasms, if it relaxes again, goes away. So this would be patient presenting with chest pain. If you give them an angio, you'd see that they're completely open. There's no plaque there, nothing to stent, and it would be very suggestive of something that we call a variant angina. So let's talk about that stable angina. Okay, in terms of its clinical appearance. First off, the history here is going to be your most important. Okay, this can distinguish myocardial ischemia from other chest discomfort. All right, so again, history is going to be important to find out. They're coming in with chest pain with any of these syndromes, of course, or any of these issues. You always want to rule out anything else that it could be, like a PE or pneumonia or a dissection of the aorta or whatever else. Okay, so you have to make sure you do a good, thorough history. But there are going to be some classic signs when it comes to this. All right, substernal crushing chest pain. Okay, often when it's stable, the quintessential stable means that there's nothing at rest, there's no symptoms at rest, but when they exert themselves, then they can actually have the chest pain. And then they'll tell you that the pain goes away when they rest. They may have had this in the past already, in which case they may say, yeah, when the pain comes on, I take nitroglycerin, right? In which, usually it's sublingual, they put it underneath their tongue, and then within a few minutes they're feeling better. Okay, and we'll get to why that is in a little bit, but that's sort of the classic presentation. Now, over here, I just want to draw your attention to this. So this is the myocardial ischemia. A couple things that can happen. You get up with a decrease in systolic function, because if the tissue is ischemic, the muscles that are being supplied by that coronary artery, they're not going to function as well. So they're not going to contract as well. But they're also not going to relax as well either. And so this is a component most people forget, is that if the muscle lacks blood supply, it lacks the energy. Lack of energy means, yes, you can't contract very well. And it also means you can't relax very well, because relaxation of muscle also requires energy. For example, calcium ATPases to resequester calcium, right, out of the cytoplasm. That requires energy. So both cases, what ends up happening is poor contraction and poor relaxation. Okay, so because of the decrease in systolic function, you can end up with a dyskinetic apical impulse. So you check for the PMI, okay, that can feel uncoordinated. All right, the pulmonary congestion can ensue because of both of these, because it backs up fluid. If I'm not ejecting it and it's stiffer, fluid backs up into my lungs, and I'm going to have trouble breathing, and so I can hear that with rails, right? Decrease in diastolic compliance. So that's going to sound like an S4, if you remember from the heart sound video. And S4 is when the atria contract into a very stiff ventricle at the end of ventricular diastole. It can cause an S4, which we call a gallop sound. Papillary muscle dysfunction, because if the ischemia affects the papillary muscle, which is part of the muscular wall, that can actually affect the valve. okay, and can cause mitral regurg, all right, because it's not functioning appropriately. So the valve leaflet, which is being tethered to those papillary muscles, it can cause a regurgitation. So you might hear a new murmur. And also there's going to be increased sympathetic tone in these patients. All right, they're under duress, okay, their heart's under duress, so they're going to be diaphoretic or sweaty, right? They're going to have an increase in heart rate, increase in blood pressure. The problem with both of these, having an increase in afterload and an increase in the heart rate due to this sympathetic output, is that you're also increasing the demand on the heart, which already is lacking some supply. All right, so you kind of see the issue already. When you're doing the physical exam, of course, you know, if the person is in acute pain when you see them, so they're still having the episode, expect to see a high heart rate, blood pressure, hearing regurg and an S4 and so on. But then, you know, you can assess for signs of atherosclerotic disease and check their carotids, check the femorals, and see if you can hear murmurs in those areas, otherwise known as bruits, okay, which are suggestive of narrow or stenotic vessels. Now, in terms of the studies you're going to order, an ECG, okay, that's going to help us look at those ST segments, any changes there. So ST segment depressions are characteristic of ischemia as well as T-wave changes. Now, in most cases, by the time you see the patient, they're probably going to be asymptomatic. The ECG may even be normal at this point, because once they've rested and it's returned to normal, the demand, supply and demand have now matched. You know, most of these physical exam signs may have gone away. The ECG is normal, but that's why the history is so important, because that will tell you this sounds like a standard sort of anginal episode. So that means you have to take it a step further. This is a patient that would need to undergo stress testing, right? Assuming they have a normal ECG and it sounds very much like anginal pain, they should be scheduled for a stress test, and then you can, you know, see if you can induce it and then go from there. So that means if it's positive, you can do an angio and possible stenting if it's really severe, or, you know, if it's negative, maybe look for another alternative explanation. So coronary angio and CTA are not routinely done in these circumstances. The coronary angio usually secondary after the stress testing. Okay. And then the CTA angio is really looking at, it's an angio of the coronaries done with a CAT scan. And it can be useful. It's not that often used, but it may be depending on the facilities you're with. And if the stenosis is greater than 50% and calcified, then it can be, it can actually help you. But any kind of stenosis under 50% is not really going to be picked up by the CTA. Some of the ECG findings, you're going to have here, this is our normal. You can have, again, ST depressions. Okay, now they can look either like they're just flat and horizontal, which is referring to that ST segment there, or down sloping, which is referring to that right there, or a T-wave inversion. So you see the T-wave is upside down, and those would all be signs of ischemia. Now, in some cases, you can have something called transmural ischemia, and it can show an ST elevation. So you notice it's elevated above the baseline. You notice over here, this was actually referred to as subendocardial ischemia. That's referring to the area in the heart which is affected. Subendocardial, so remember the endocardium is the innermost layer. That is the most common area of the heart to become ischemic, because remember the large coronaries are in the epicardium and they branch inward, and the smallest ones, the ones that are most easily impinged, would be the ones in the subendocardial space. So they're usually the ones affected first. Transmural means the entire thickness of the wall. Trans and mural means across the wall, right? So the entire thickness of the heart wall is ischemic, and that shows up as an elevation. And so elevations, as we'll learn with myocardial, they show up in myocardial infarction, as we'll learn, but it can also just mean ischemia. There may not be any infarcted tissue there. This may be seen here in something like Prinzmetal's, where you have a spasm that's so severe it's affecting the entire thickness of the wall, and you're seeing an ST elevation. In terms of the treatment for this, in the acute episode, what happens is you cease physical activity, right? Reduce the demand, and then take nitrates. Now, nitrates are useful because what nitrates do, they primarily venodilate. They dilate the veins, which decreases venous return. In decreasing venous return, you decrease the preload, or the amount of blood that's returning to the heart. That decrease in load on the heart will also help to reduce wall stress. Remember, that's another thing that requires energy, so that's helpful. And there's an added function of the nitrates in that they dilate the coronaries. And so that actually helps to further dilate them, and that can be very helpful to increase that perfusion. So that's sort of a mainstay for patients with stable angina. Now, we want to also prevent any recurrent ischemic episodes. Keeping in mind that to reduce recurrent ischemic episodes, we have to reduce the demand. Okay, so that means, if we want them to be able to exert themselves or something like that, so we have to make sure we control that heart rate and that contractility. Beta blockers. Now, beta blockers, they don't reduce mortality in this case. I've highlighted in red as it decreases mortality after a myocardial infarction. But in stable angina in somebody who hasn't had an MI, it's not been shown to reduce mortality, but it is very, very helpful because it reduces contractility and heart rate. It also increases the time in diastole, right? And that means increases the amount of time for the coronaries to perfuse, which is also helpful. Nitrates in combination with that, because nitrates, again, reduce wall stress, dilate the coronaries. Calcium channel blockers. Calcium channel blockers are similar to beta blockers in that they'll reduce contractility. They can also reduce the heart rate. They also can cause vasodilation, both of the arteries, so it reduces afterload, reduces preload, and it can also dilate the coronaries. So it would seem sort of like the ideal choice. However, they've discovered through a couple of experiments that the long-acting calcium channel blockers can actually increase mortality. So for that reason, we usually have our first line as a beta blocker. And if we're going to use calcium channel blockers, usually the shorter acting. Now, if I want to prevent an acute cardiac event, meaning I want to prevent thrombosis. Remember, they're always at risk of thrombosis because of that endothelial damage. I have to modify their risk factors first off. Stop smoking, control their diabetes, lose weight, and so on. In addition to that, I'm going to add an antiplatelet therapy, which means aspirin. Now, clopidogrel is another antiplatelet that can be added in conjunction with aspirin in some circumstances. All right, so you may have heard of the term Plavix, so aspirin and Plavix, but aspirin and clopidogrel, they have two different mechanisms, but both will inhibit platelets. Clopidogrel, as well as another one called ticagrelor, and there's others, they inhibit the ADP receptor on platelets, and ADP can activate platelets. So it's inhibiting ADP's ability to do that. So that helps to reduce the risk of these platelet activation. Statins will help to lower cholesterol. It's also, they're both highlighted in red, aspirins and statins, because they do reduce mortality. So they can help reduce the LDL. And there's no bottom limit to reducing it. We want to reduce it as low as we can possibly get it and use as high a dose as we can use. ACE inhibitors would also be useful for controlling afterloads and preloads because it's a vasodilator. And as we know from the heart failure lecture, it can lower mortality in those cases. So that would be on a patient-to-patient basis. Revascularization. So that's a big question is, do we revascularize patients with stable angina? Under most circumstances, no, we do not. We end up just medically optimizing them, as we call them. So we put them on all the appropriate medications that I just spoke about. However, if we stress test them, all right, we're going to stress test them to risk stratify them, all right, to see how bad the test looks. And if the stress test is very positive, we can then opt for an invasive strategy like an angiogram and assess those coronaries and see if there's stenotic vessels. And they would be at higher risk, let's say, if they had greater than 70% stenosis, based on the previous slides that I talked about. And then they can undergo a PCI, which is a percutaneous coronary intervention, which is essentially you insert a catheter, and then the catheter can, in some cases, just inflate a balloon and crack open those vessels. That's not done as often anymore because they do re-stenose more often, but more typically it would actually be with a stent. So you use a balloon with a stent, the stent stays in and keeps it propped open. You can also, in some cases, they might opt for a coronary artery bypass graft, where they're actually using vessels from somewhere else in your body, like a vein, like the saphenous vein, and reconnecting conduits around the stenosis. So these would be options if we think that this patient is at very high risk. And the way we would know that, again, is by stress testing them so we can stratify their risk. The patients at highest risk would be multiple vessel disease, like 2 to 3 coronary vessel disease, greater than 70% stenosis, and any kind of left ventricular malfunction. So if the ejection fraction drops, all right, below 50%, they're at higher risk. So this is just a management decision kind of guideline here. And if we take a look, this is risk factor modification and aspirin are indicated in all patients. Okay, so that's something that they should be on. Assuming, again, there may be a few people that may have reactions to aspirin, in which case you work on that on an individual basis. All right. Manage according to the risk. So if they are low risk, meaning it's mild, normal ejection fraction, mild angina, they have a single vessel disease, for example, nitrates and beta blockers, you might consider a calcium channel blocker if the first two don't work entirely. So you can have them on all three. If it's moderate, moderate's essentially the same treatment. That just means, normal EF, they may have two vessel disease, symptoms are a little bit worse, same medical regimen. Okay, but in this case, you might consider coronary angio to assess revascularization if we think it might be helpful if somebody's having some severe symptoms maybe. Now, if it is severe, so they have severely symptomatic, they have a decreased ejection fraction, less than 50%, severe angina, 3 vessel disease, left main, the left main would affect most of the left ventricle, then coronary angio and consider, a CABG, coronary artery bypass graft, or a PCI. Just to give you an idea, these coronary stents that are used for PCI, all right, so when we talk about percutaneous coronary intervention, excuse me, so PCI, insertion of a catheter, which on the tip of the catheter has a balloon that, as you see, gets inflated and has a stent around it, and the stent stays in. And the stent basically props open that stenotic region right there. Basically, you're kind of crushing back the atherosclerotic walls there, which increases the lumen diameter and increases flow. Now, in conjunction with doing that, you have to put them on, usually a dual antiplatelet therapy, aspirin and clopidogrel, or clopidogrel and ticagrelor, some other combination. Oftentimes, though, these stents also have what they call drugs that are on the stent itself. So these are referred to as drug-eluting stents. So they're coated in this drug, and you'll see it written in charts as DES. So it looks like stent with DES, which just means it has this drug-eluting stent. And these are anti-proliferating. So sirolimus is an example of one. What that basically means is when you leave the stent in, if it didn't have this drug on it, what happens is the tissue kind of grows in and around the stent itself, and as it grows in and proliferates around it, it can actually cause a reocclusion, which is something that does happen with bare stents. Now, in the drug-eluting stent, it prevents or inhibits that from occurring, so it helps to keep the stent patent for much longer, so it's usually more desired. Okay, so now moving on from stable angina, the progression is typically with a patient who has stable angina will then progress to things like unstable angina, to a myocardial infarction, and so on. So this is really part of a continuum, if you will. And so we'll talk about that continuum. And that's, to keep in mind that some patients may not have the classic stable angina before they're presenting with an MI. They may not have any symptoms at all. And that's not uncommon either. So it's something to be aware of, that at least I think somewhere around 25% of the population can have silent ischemia. So ACS, or acute coronary syndrome, all right, this really has 3 components. That's unstable angina, all right, a non-ST elevation myocardial infarction. The non-ST is referring to the ECG finding. And then an ST elevation myocardial infarction, or a STEMI. Those are the 3 types of ACS. Now, 90% of ACS results from disruption of an atherosclerotic plaque, meaning that coronary artery disease that I spent time talking about in the beginning of this lecture. But keeping in mind that there are other causes that can lead to an ACS type picture. I mentioned one earlier on, like hypotension, severe hypotension could do something like that by reducing perfusion pressures. Now, both the unstable angina and the NSTEMI are characterized by a partially occlusive thrombus. So what characterizes actually all 3 of these is that a thrombus has formed. The first two, unstable angina and NSTEMI, have partial occlusions, which means some flow is going past it. But a STEMI, all right, is typified by completely occluding the coronary. Okay. So in terms of its thrombus formation, all right, what you have is a platelet plug forming, coagulation cascade, and inappropriate vasoconstriction due to that damaged endothelium are all combinations that lead to this. In brief, keeping in mind a normal endothelium has anticoagulant properties. So nitric oxide and prostacyclin, for example, inhibit platelet activation, but it also has anticoagulants in the blood, like antithrombin 3, which binds to heparin, protein CNS, which binds some of the clotting factors. The tissue factor pathway inhibitor blocks the external pathway with tissue factor when it's bound to factor 7. And fibrinolysis, normal healthy endothelium can release TPA or tissue plasminogen activator, which is then can activate, ultimately end up activating plasminogen into plasmin, which is plasmin is the only thing that can actually degrade an existing clot. The rest of these help to prevent the clot from forming. The plasmin is the only thing that can actually degrade it once it's already formed. So if I have a dysfunctional endothelium, as I've been mentioning, decreased vasodilator effect due to the loss of nitric oxide, which is one of the main promoters of vasodilation, and antithrombotic, a decreased antithrombotic effect. So vasoconstriction and then a coronary thrombus, the combination is going to reduce that lumen significantly. When the plaque ruptures, which is the characteristic finding of what happens in ACS, you can have a hemorrhage inside the plaque itself, so you can get blood moving inside that plaque, which can also expand it. You can get release of tissue factor because the tissue is damaged, and that activates the coagulation cascade. You have exposure of the collagen, which activates the platelets. And you can actually have turbulent flow around stenotic vessels there, and turbulent flow also can lead to stasis and coagulation. So it's sort of a perfect storm into leading to clotting. Coronary thrombosis, okay, plaque rupture, endothelial dysfunction, and those are really the main reasons that I've already talked about, so I won't go into that too much on this slide. But I did want to point out quickly here the non-atherosclerotic causes of MI. As I mentioned, 90% are caused by this, but you could have an embolus that came from somewhere else that happened to wedge it into the coronaries. You could have a vasculitic type syndrome, all right, where it's maybe more diffuse, in which case you might see other types of symptoms that would suggest that particular type of syndrome. Connective tissue disorders, like a Marfan's type picture, which can cause dissections, which are tears in the intima of the aorta. And we'll get into more of that in a different video on peripheral arterial disease video. Dissection, which is actually really kind of related, which I've already mentioned here. And then things like drugs, cocaine, which can induce an increase in heart rate. So, for example, you could have extremes in heart rates that create a high demand, more so than can be supplied. And so anytime you have a mismatch in your supply and demand, you're going to have this issue. So in terms of the infarct, all right, so now when we talk about infarct, we're talking about dead tissue. Not all of the ACS syndromes or the ACS has infarcts. In fact, unstable angina, it's ischemic but not infarcted tissue. Okay, but once we get into the NSTEMI and the STEMI, the other two, they can have infarction. Okay, in fact, they're quite common in those. So when we talk about infarct, we're talking about dead tissue, something you could find in an NSTEMI or a STEMI, and it could be either transmural or subendocardial. And as I've described earlier, that just means on the location of where it's occurring. Most commonly, you can see it in the subendocardial. So just to give you an idea what this cartoon is showing you, this is actually a cross-section of the ventricle. So this would be the left ventricle, so it looks more circular. And right next to that would be the right ventricle, which typically looks more like half-moon shaped, okay, or crescent shaped. So subendocardial, that little white sliver there is representing the subendocardial region, which is just underneath the innermost layer, the layer that's the most often affected. Transmural, as you can see, the white layer goes the entire thickness of the wall of the left ventricle in this circumstance. So that's affecting the whole wall. That's usually more severe ischemia, which can also involve infarcted tissue. So the infarct can either be subendocardial or transmural. The infarct, in terms of the infarction itself, how bad it is, or how much of the heart it affects, it really depends on the mass of the myocardium that's being perfused by the occluding vessel. So if it's the left main coronary, that's a large area of the left ventricle that's being perfused by that. And so therefore that could be a very large area and a massive amount of tissue that's being damaged. Now the magnitude and duration of the impaired blood flow. So how severe is the stenosis? And is it completely occluded or not? How long was it occluded for? And this all plays a role in the amount of tissue damage, and I've kind of already alluded to that, or I've talked about that in earlier slides. Also, the oxygen demand. Okay, so how high was the heart rate going? How much contractility was there? What was the wall stress? These are things that we're going to be looking to reduce to help to preserve muscle tissue from metabolizing too much and causing its own damage. The adequacy of collateral vessels. So this is actually important to understand, is that somebody who's had chronic heart disease and maybe chronic stable angina, let's say as an example, they may have formed collateral vessels where there's ischemic tissue that other blood vessels have grown into that area and help to feed that tissue, and so we call that collateralization, or collateral vessels. And this is where somebody who has chronic disease may actually be at an advantageous position over somebody who doesn't have this chronic disease, because somebody who doesn't have this chronic disease and they show up with an acute episode, they have no collaterals per se, and so there's no added blood flow to a region to help preserve it. Whereas in a chronic disease, they may actually fare a little bit better under the same circumstance given the collateral flow. And again, it depends on how much collateral flow they have and so on. Now, the degree of tissue response that modifies the ischemic response, how responsive is the tissue, and to what degree does it respond, will play a role as well. So to kind of give you quickly an idea of the pathology that's involved with this, there's really an early and late stage to ischemia and infarction. And what happens is, in the early stage of ischemia, you have hypoxia. So you get those ischemic changes that I noted earlier, where you undergo anaerobic respiration, buildup of lactic acid, and so on. So the pH level starts to go down and become more acidic as those acids build up from metabolism. The lack of oxygen means you're not producing as much ATP. Lack of ATP means things that rely on it, like contractility and so on, will be malfunctioning. But then at the same time, those cells are going, the ATP, the sodium potassium pumps, which rely on ATP, won't be functioning well. So you're going to have a distribution of electrolytes that's abnormal. The sodium is going to be accumulating inside the cell, which can also draw water in it, make them swell. Potassium is outside the cell accumulating, and that can actually cause conduction abnormalities and even arrhythmias as potassium levels increase. So there's a host of steps that go on, which you can look at this cartoon for that. But this goes into that cartoon, this kind of goes into more detail than I'm going to be talking about. But one of the main concepts is in the early stages that really you get myocardial dysfunction within about 2 minutes, and it can become irreversible or irreversible cell injury in about 20 minutes. All right, so this is where time equals tissue, so to speak, where we want to reperfuse and get that blood flow there as quickly as possible, or lower the demand as quickly as possible to salvage what we can, because the muscle doesn't regenerate. Now, in the late stages, what happens? Let's say we have infarcted tissue and it doesn't regenerate, so we have dead necrotic tissue from an infarct. What's going to happen is now all this dead cellular debris has to be cleaned out, and so the monocytes turn into macrophages, which go in there and they'll actually start to gobble up all this debris to help remove it. But in doing so, it can actually cause thinning of the thickness of the wall, because it's taking away and removing tissue, including some collagen that might have gotten laid down and so on. And this usually occurs anywhere from 5 to 7 days after an infarct has occurred, and so it goes in there. So the importance of the timing of this is that if the macrophages come in there and thin the wall out in about 5 to 7 days, that can cause a temporary weakness in the left ventricle, or in the ventricular wall, a week out from the infarct. And the relevance to that is, if the heart is still pumping and generating a lot of pressure, and a portion of the wall is thin, that portion of the wall can kind of balloon out, okay, and create what we call an aneurysm. And that aneurysm itself could actually rupture and cause bleeding and hemorrhaging and what we call a tamponade, which we'll talk about, which can, blood accumulating around the heart and compressing it. So that can become very dangerous, about a week after the infarct has arisen. So we have to be aware of this particular tissue remodeling stage. And then finally, what's going to happen is you're going to have migration of some of the tissues and deposition of, collagen to form a scar tissue, and you end up with a portion of the wall that is now scarred and doesn't move as well. So you can see that on an echo when they see that the ventricular portion of the ventricular wall is not contracting or moving like the rest of the wall. And that's due to the fact that it's non-contractile tissue there now. It's collagen, okay? Which, if there's enough of it, can make it a very stiff wall and make it a little bit more rigid. And it's non-contractile. Okay, so it's not functioning, and in addition, this can also affect the conducting pathways going through there. This can lead to arrhythmias down the road as well, if not immediately. So the functional alterations that occur with this scenario, as I mentioned, impaired contractility and compliance, and some of the terms refer to those as hypokinetic, meaning reduced contractility, akinetic, meaning no contractility at all, dyskinetic, and that's really what happens when you have sort of that aneurysm. So as the heart contracts and increases pressure internally inside that ventricular chamber, it causes the wall to bulge out at the same time when there's a weakness. So they call that dyskinetic. So this can lead to a drop in cardiac output. All right, so blood pressure can drop. Then we have the stunned myocardium, which I mentioned earlier, which is usually just a slower recovery. The ischemic preconditioning, that's what I mentioned before, where in terms of an infarct, in context of recent angina, you're going to experience less morbidity and mortality than those without preceding episodes, because they may have had more collaterals and so on, and more adaptations that have happened on a cellular level that help actually help the patient to survive better than somebody who has not had those adaptations. And then finally, ventricular remodeling, the early and late that I mentioned on the previous slide. Clinical features of the acute coronary syndrome. So now we're kind of getting into more of the details of each. The unstable angina. So now, if we look at this as a continuation from stable angina, this is somebody who's going to have what we call a crescendo pattern, where now the symptoms are getting worse, they're lasting longer, and they may be occurring at rest. Okay, so those are the classic, whereas now it's occurring at rest, lasting longer, and the symptoms are more severe, and they may be happening more frequently. Now, in the acute MI, where you have myocardial infarction, that's an NSTEMI and a STEMI. Okay, this is severe angina, so this lasts longer. Okay, doesn't subside with rest, and I mentioned before, 25% of this can actually be silent. There's little response to nitrates because at this point, if it's occluded, it doesn't help much, and they're usually already maximally dilated. It's a very strong sympathetic response. Okay. Blood pressure can go very high, heart rate can go very high, very diaphoretic. Large amount of myocardium can result in left ventricular systolic dysfunction with an increase in diastolic pressure, meaning it's not relaxing well either, right? Physical findings would be similar to what we've talked about though. An S4 or an S3 can be found. All right, you could have rupture of the papillary muscle, and again, that could cause a murmur, which can actually exacerbate the whole problem due to volume overload. Inflammation, they could have a fever. They can be dyspneic due to fluid backup in the lungs, tachycardic, weak because of the low cardiac output, and so on. Now, in terms of their diagnosis for one of the three of these, it's fairly straightforward actually. So it's the patient's presenting symptoms that are typical of angina. All right, some of them may be atypical, particularly if you have patients or diabetic, elderly. Sometimes this happens more often in women than men, where they don't have typical anginal type pain. So we refer to the non-typical type as anginal equivalents. All right, so that's something we'd have to kind of work through. The ECG. So the findings on the ECG, they're presenting symptoms, the ECG, and then we're going to draw blood and look for specific serum markers of myocardial necrosis. Okay, these are referring to things like myoglobin, CKMB, and troponins. So we're going to draw and test for those three, and they will be indicators of necrosis. They do not elevate in ischemic episodes, only if tissue is dying. So it's important to understand. So with unstable angina or UA, There's the classic clinical appearance, all right? ST wave abnormalities, which usually is going to be ST depressions, and the absence of serum biomarkers. So I underline that. So there's no serum biomarkers because there's no necrosis. NSTEMI is going to have more persistent ST wave abnormalities, so depressions, T wave inversions, plus elevated serum biomarkers. So that's differentiating it from the UA. Then finally, the STEMI differentiates from either one of those because it has ST elevation MI and elevated serum biomarkers. And I put this little grid over here so you can kind of see more of the specifics, which I'm not going to talk about right now because you can read that for yourselves. But it tells you about elevations in the ST segment or depressions and to what level they could be considered, ischemic or infarcted and so on. In terms of the ECG abnormalities, here this is sort of the classic progression of an ST elevation MI. So if I have my normal, all right, you can see here after the occlusion occurs, you have the elevation of the ST segment. So this is sort of the classic, and this is what we really rely on. You can also see sort of a decrease in the amplitude of the R wave there, and this would be our R wave right here. Okay, and you see further decreases in amplitude. That's fairly typical. You can see the ST elevation, and what you're seeing here in the progression is the formation of a Q wave. And then you see in 4, here's still the Q wave and the ST elevation. Our Q wave, the elevation is gone, but we have an inverted T wave. And then finally, we're left with a Q wave. And so the Q wave we don't use in an acute scenario to diagnose an infarct, but Q waves usually stay for the life of the patient. And so what happens is the Q wave actually acts as, and I should say an abnormal Q wave. An abnormal Q wave acts as an indicator or a marker of a prior infarct. So it can be useful to see that on ECG. Okay, especially if the patient had, say, a silent infarct. They had no pain or any kind of symptoms like that, and you see these Q waves. Now, for UA and NSTEMI, the ST segments would actually be depressed, not elevated, and you might see T wave inversions. For the STEMI, you would see the elevation or the evolution of which I just talked about, and it happens fairly rapidly to see that ST segment elevation. In terms of the biomarkers, I mentioned myoglobin, troponins, and CK-MBs. Myoglobin, now myoglobin is what you can see here on the graph. All right, here's the troponins and here's the CK-MB. Myoglobins are non-specific, okay? It's not specific to the heart at all. However, it will be drawn early on if the patient comes into the emergency room. It's drawn right away because it's the fastest one to elevate. So you can see by the slope right here. So this is the slope, okay? This is, again, days after onset or whatever. The myoglobin can rise within an hour or two. So myoglobin goes up the fastest. Since it's non-specific, if it's elevated, it doesn't tell me much. Okay. However, if it's not elevated, that suggests that it's probably whatever the symptoms are is not being caused by necrosis of the tissue, of the heart tissue. So if it's elevated, I still have to look at these other labs. But if it's not elevated, it definitely suggests that there's not necrotic tissue in the heart. However, now we have the troponins and CK-MB with both elevate somewhere around 3 to 4 hours, or upwards of even 8 hours or so. And they're both indicators and fairly specific indicators for heart necrosis. Okay, and the difference between the two really is that although they rise in a similar timing fashion, troponins last a lot longer. They can last upwards of even 10 days. They can stay elevated, whereas the CK-MB will usually drop off after about 48 to 72 hours. So about 2 to 3 days, it usually goes back to its baseline level again. This is useful because with the CK-MB, if we have a patient who's admitted to the hospital, we see that these levels are rising. And by the way, they rise in accordance with severity. Okay, so the higher they go, the more severe it is. Now, when they rise, the CK-MBs, if they're there for a few days, if they're there for 4 or 5 days, the CK-MBs may have already dropped off. Okay, the troponins will stay elevated. The patient still can have another infarction, even though you've treated the first one. It may have another one. And so the CK-MB will rise again. The troponins may not change at all. And so it's a good sort of indicator for a reinfarction. Not to mention the symptoms that they'd be having and all that, but it helps us to kind of to narrow that down. We can see the CK-MB rise again. So it's useful for reinfarctions as well. Now, We'll usually trend these. By trending, what I mean is you don't just draw it once and take a look at the level. What you do is when the patient comes in, you take blood right away, you see what the levels are, and then every 6 to 8 hours, you're going to repeat these blood labs and see where it's trending, where it's going to. Is it going higher and higher, or is it starting to taper off, and so on. This is important to do because, one, it tells us, gives us more information about the extent of what's happening. But at the same time, you're going to have patients who have, say, chronic kidney issues or disease or kidney failure. Those types of patients will already have elevated troponin levels, for example. So if you go in and take only one lab, you're not going to be able to know if that troponin itself is actually, secondary to their kidney disease, or if it's because of this acute MI. And by trending it and seeing it going upwards, that will help to differentiate that as well. All right, so let's talk about the treatment of the UA and the NSTEMI. So these are the first two in the ACS, not the STEMI. So we're leaving out the STEMI specifically here. Now, if you remember my balancing board here, where we're talking about, supply and demand. So keep that in mind. So we want something that's anti-ischemic. What we're really saying is, let's reduce the demand. Okay, so if we reduce the demand, beta blockers. I've highlighted everything in yellow that can lower mortality. Beta blockers will really only lower it after a STEMI, okay, but we'll still use it here as a first-line agent. So this patient may have had a previous STEMI, so I left it as yellow, but understand if not, it may not be lower mortality. But beta blockers, reduce contractility, reduce heart rate, increase time for coronary perfusion. So it's going to be one of our first-line agents. Nitrates, we'll add nitrates to the mix. That's going to reduce the preload, dilate those coronaries. That helps to reduce wall stress. So these are all what we call anti-ischemic. Calcium channel blockers may or may not be added depending, as for the reasons I've discussed earlier with stable angina, but same principle. In this case, now with stable angina, we did not anticoagulate. All right. In the cases of ACS, when it comes to UA and STEMI, right now the criteria suggests that we anticoagulate. So that means in addition to aspirin and clopidogrel or ticagrelor, which I mentioned, you can use that for stable angina. You're going to do the same thing here. Dual antiplatelet therapy, or DAPT, lowers mortality. So it should be given to these patients, okay, if they're not already on it. And the anticoagulation, now we're talking about adding heparin, okay? Heparin, either unfractionated heparin, which is where you actually give it IV, and you have to check a PTT, and you have to give boluses, and you have to repeat labs all the time to readjust it. It's a lot of work, but it's also something that's easy to start and easy to reverse. Now, low molecular weight heparin is another formulation of this. The advantage to this is that you can give it sub-Q, and you only have to do it every 12 hours or so, and you don't have to check labs. But it's not as reversible. So in certain circumstances, we want it to be able to reverse, like if we're going into a procedure, we want to be able to reverse it quickly, we may go with unfractionated. But they've found that enoxaparin, which is the low molecular weight heparin, also referred to as Lovenox, this has shown to actually work very well in terms of reducing ischemic events prior or after the fact. So I put that there in yellow, even though it's still debatable whether or not it actually reduces mortality. Adjunctive therapy. So this is in addition to, right? So this is going to be things that will also assist. ACE inhibitors, reduces preload and afterloads. The statins will help lower mortality in that lower cholesterol levels and LDL levels. And again, there's no real bottom level that we're trying to lower to. We get it as low as we possibly can. ACE inhibitors do lower mortality, so I've highlighted it there in yellow. Warfarin, which is an oral anticoagulant, may or may not be necessary depending on whether or not they have any indication of an increase in thromboses, say atrial fibrillation or something of that nature. Now, finally, so the patient comes in, you're giving them these medications. All right, you've already diagnosed as a UA or an NSTEMI, and you've optimized them medically. And what you see here at the top, all right, those are all the medications that I've just mentioned. There's a couple of extras that you may notice. I hadn't mentioned yet GP2B3A, which is an antiplatelet. In some circumstances, if they're going to be going for a PCI, you may be adding this 2B3A inhibitor, which is another type of platelet inhibitor. In terms of anticoagulant, this means unfractionated heparin versus low molecular weight heparin, and the bivalirudin one is actually one that can be used in certain circumstances. It has a lower risk of bleeding, for example. All right, so now you've medically optimized them, okay? And most patients within about 2 days with this medical optimization will recover, okay? But the next step is you have to evaluate their risk. Okay, you can't just necessarily just send them home and say, okay, enough's enough. We have to actually evaluate the risk. And there's various ways to score them. There's one called a GRACE score. The one I picked to show you here is called a TIMI score, or thrombolysis in myocardial infarction. This predicts the likelihood of death or a subsequent ischemic event after the fact. And so if they score a 3 or greater on this scoring system, that suggests that you should now institute an early invasive strategy, meaning you should probably go for an angio, and then, and that can be followed by a PCI or some other, maybe a CABG, or depending, okay, some invasive strategy, okay, because the question becomes, if I medically optimize them and they've had a UA or an NSTEMI, should we be invasive or not? And this TIMI will help you to stratify them, okay? So once you medically optimize them, you're running the TIMI, and you take a look at the scores. If they're above the age of 65, that's a point. If they have greater than greater than or equal to 3 risk factors for coronary artery disease, so hypertension, diabetes, dyslipidemia, and so on. If they used aspirin in the last week and they still had this event, okay, that's high risk. If they've actually had an angio in the past and you know that they've had a stenosis that's greater than 50%, greater than 1 episode at rest in less than 24 hours, ST segment deviation, so depressions or elevations, elevated cardiac markers. Okay, any one of those puts them in a higher risk category. Now, again, 1 or 2 of those, that's a gray area. But once you hit about 3, then that would suggest, invasive strategy. So here's the general treatment guidelines for this. If somebody comes in with a UA or an NSTEMI, admit them to the hospital, on the floors or in, a cardiac unit. They're going to have continuous monitoring hooked up to ECGs. You got to establish an IV, give them supplemental oxygen if their saturation is less than 94%. You don't want to give oxygen to just everybody. If they're having difficulty breathing and they're satting under 94%, then you can give them oxygen. Again, oxygen will help to increase their oxygen content, which helps to increase their supply. So it's helpful. Pain and symptomatic control with nitrates and morphine. Okay, nitrates can help to eliminate some of that pain. Morphine is an option as well if the pain continues. If they can't take morphine, you can give them some other type of analgesic. Aggressive medical management, that means you got to start them on the aspirin, start them on a beta blocker, as quickly as you possibly can. The thing about the beta blockers, and I'll mention this now, which I should have mentioned it a little bit earlier, is that there are some contraindications to using a beta blocker in some patients. So just to be aware, you know that a beta blocker reduces heart rate, but if the patient is already bradycardic, you can't use it then. If their blood pressure is very low, you wouldn't want to use this medication. Okay? If they just went into an acute systolic heart failure, as I mentioned in the heart failure lecture, you don't want to use beta blockers. In fact, you're going to withhold them. So then you might have to opt for alternatives. Heparin is going to get started, low molecular weight or unfractionated, depending. Okay? Again, the benefits of using this is going to be that the unfractionated requires checking a PTT continuously, but the benefit is it's easy to reverse and it's easier to control. The low molecular weight heparin only requires like a once or twice a day dosaging. It can be done subcutaneously, and you don't have to check the labs. And an example of that's the enoxaparin. Glycoprotein 2B and 3A, as I mentioned on the previous slide, might be used if they think they're going into a PCI. And if you run the TIMI score and you risk stratify them and the risk is high, above 3 or greater, then angio and consider revascularization with a stent or coronary artery bypass graft and so on. So one of the quick ways to remember this when we talk about giving medications quickly to the patient coming in with a UA or an NSTEMI is something called MONA. So MONA stands for morphine, oxygen, nitrates, and aspirin. That's sort of your standard concoction there. Keeping in mind that doesn't mean that's the only thing you're giving them. You still have to give them the anti-ischemics and so on. And with aspirin, you're going to want to add another anti-platelet. So, for example, aspirin and clopidogrel or ticagrelor, for example. Okay. Treatment of an acute STEMI. So now we're talking about the STEMI. Okay. This is really rapid reperfusion. You're still going to medically optimize. You're going to give the medications as fast as you can, but the goal here is really to get them into the procedure as quickly as possible. And so by procedure, what I mean is you want to get them in for a PCI or a percutaneous intervention rapidly, or you want to give them fibrinolytics, which I mentioned, TPA, a tissue plasminogen activator, which activates plasmin, which breaks up existing clots. Because remember, this is a total occlusion. There is no perfusion downstream of it. So the whole goal here is to reperfuse as quickly as possible. So the guidelines say this, that if they've had symptoms for less than 12 hours, okay, symptoms for less than 12 hours, as soon as they get to the hospital, then you want to get them into PCI as quickly as possible. In fact, PCI is preferred over fibrinolytics because PCIs reduce mortality more so than fibrinolytics. Both of them will reduce mortality, but PCI is better. Now, not all hospitals will actually perform PCI. Okay, so the goal is, if they're en route, hopefully the ambulance can get them to a PCI capable facility. Okay, if on the other hand they take them to the hospital that doesn't have it, if there is one that is close or is nearby, then you should transfer them. So that's how important it is to get them to the PCI. Now, in terms of the timing of that, this means that by the time they enter the door of the hospital, okay, or their first medical contact is another way to put it, as soon as they have that first medical contact, you want them in the PCI in under 90 minutes. So this is quick, okay? So in other words, they've been asymptomatic for less than 12 hours. They get them into the hospital, get them in the PCI in under 90 minutes. If you have to transfer them, so there's a hospital nearby that has PCI, then get them there as long as they can get them into the PCI in under 120 minutes. And that's so we'll go with that. If you cannot, if it's not PCI capable, and you can't get them within that time frame, then you can opt for the fibrinolytics. That has a higher risk. It's not risk of bleeding and so on. So this is the secondary option. In terms of timing, you may want to go with the fibrinolytics, especially if you can't get them to the PCI. So therefore, adding the tissue plasminogen activator. There's several variations of it, like retiplase and tenecteplase and so on. And if you're if that needs to be done, that should be done in less than 30 minutes as soon as they meet. Now, usually we talk about this, first medical contact with PCI or fibrinolytics. Sometimes it's also referred to as door to balloon time. It just means get them in there as soon as possible. Okay, as soon as you possibly can, and salvage as much of that tissue as you possibly can. Okay, so that's the goal. So over here, I'm just comparing the STEMI to the UA and the NSTEMI. So here's STEMI, here's UA and NSTEMI. When it comes to the STEMI, we just talked about that. This is emergent PCI. Is it available within 90 minutes or at least 120 minutes by transfer? If yes, then that's what you're going to do. If no, then fibrinolytic therapy, as long as there's no contraindication to the fibrinolytic therapy. There's a lot of gray area when it comes to this, though, because it could be on a per patient basis, whether or not they can take fibrinolytics, whether or not they can get PCI. You may have to actually even opt for a cabbage in some circumstances. So this becomes very dependent, and there's a lot of gray area here where if it's just over 12 hours, so should we still do a PCI or medically optimize them and so on. And we can discuss some of those ins and outs a little bit when we talk about this live. Now, in terms of the UA and the NSTEMI, remember, you're medically optimizing them. That's your first goal. Then you do the risk assessment, right? So you're looking at their troponins, their ECG, and you're doing the TIMI score. You do the TIMI score, all right? If it's low, conservative strategy, medically optimize, and then you can have follow-up, okay? And if it's high, then it suggests the invasive strategy. So this all around gives you a good kind of picture of what to do with these patients. So in general for the STEMI, this means total occlusion. So in hospital, you'll notice the procedures and the medical management is essentially the same as it was for UA and an NSTEMI, okay? You're adding all the same medications like aspirin and ticagrelor, beta blockers, ACE inhibitors, statins, and so on. All the ones highlighted in the yellow will reduce mortality. Okay, heparin, the choice is up to the usually the physician or the hospital. Unfractionated heparin is usually preferable for the reasons I said, that you can kind of control it and measure the PTT more rapidly, and getting them in there for revascularization. Now the in-hospital measures, same thing: IV access, continuous monitoring. They may get a catheter to assess pressures in their heart, so like a pulmonary capillary wedge pressure, which is what PCWP stands for, particularly if they're hemodynamically unstable. Okay, so this can give you a quick way of measuring if there's changes in their pressure, and you can see it more rapidly and definitely more accurately. And then, obviously I highlighted in bold here, the PCI versus fibrinolytics. That's your mainstay. That's what you're really going for as quickly as possible. Okay, with PCI being the preferable. And then after all is said and done, there's going to be a period of rehabilitation. Now, after the acute treatment, which I have over here, you're going to continue the medications. All right, aspirin indefinitely, beta blockers, ACE inhibitors, statins, and of course a secondary antiplatelet, which is also referred to as a P2Y12, which is the ADP receptor inhibitor that I mentioned. This is clopidogrel, ticagrelor. That may be continued from 12 months or more, all depending on the situation, and of course reduce their risk factors. Okay, so this is sort of the standard treatment. This doesn't take into account all the individual cases that could come up and all the gray area that there is with these situations. For example, somebody who has contraindication to aspirin or beta blockers or ACE inhibitors and so on. These are smaller percentages of people that we'd have to deal with when those circumstances arise. In terms of the prognosis, the best predictor of prognosis after an MI is going to be based on their left ventricular function. We can measure that with an echo and measure the ejection fraction. The ejection fraction is a good standard to measure left ventricular function. Okay, so standardly between 50, 60, or 65% is a normal ejection fraction. Less than 50% is reduced. The lower it is, the poorer the prognosis. Standard discharge therapy is what I've kind of already mentioned on the previous slide. Okay. The only thing I wanted to add to that is looking here at if there is a low ejection fraction, like let's say less than 30%, they might be candidates for an implantable cardiac defibrillator or an ICD. And what that does is, if they have a low EF, that's usually a very unhealthy heart. They're more prone to arrhythmias like VFib or VTAC, for example. And so you have to wait, obviously, about 40 days or so after the MI, because you can't do it right away. But you implant that, and it can help to reduce their risk of mortality or morbidity from those arrhythmias. And then finally, just quickly here, warfarin for something like AFib, so they might have to be on an anticoagulant, possibly, depending. And so finally, in terms of complications from ACS, keep in mind that you need to be aware of these because they are fairly common. And they can be life-threatening, and the other things that need to be addressed. So I'm going to look at the chart over here first and just point out that we have, underlined in red already is our myocardial infarction. And then what can happen is, as you already know, we can have reduced contractility. Okay, because of the reduced contractility, or that can lead to a low cardiac output and produce hypotension. Hypotension can reduce coronary artery perfusion because now you have low diastolic filling pressures. That can lead to more ischemia. So you can see this is a vicious cycle. That can lead to more decreased contractility and so on. So it's a very vicious cycle. It can also lead to cardiogenic shock. And we'll talk more about the specifics of that in another lecture. Now, in addition to the reduced contractility, you have more blood stasis, which means you're at higher risk for a thrombus, which can form an embolus. Okay, and that can travel anywhere and create strokes and so on. The scarring and dying of the tissue and so on, this can lead to electrical instability and affect the conduction pathways, leading to arrhythmias like AFib, VFib, VTAC, okay? Tissue necrosis, all right? The tissue necrosis can affect the papillary muscles, leading to mitral regurg, can lead to a ventricular septal defect if it's infarcted the septum. it cause ventricular rupture like the aneurysm that I kind of mentioned before. That can lead to something like tamponade. Having a septal defect or mitral regurg can lead to heart failure, okay, like congestive type heart failure. Finally, pericardial inflammation. This is an inflammatory reaction that's occurring that could extend to the tissue that surrounds the heart, the pericardium, and lead to something called pericarditis, which is just an inflammation of the pericardium. And it can actually represent or appear like another infarct when in fact it's just inflammation of the pericardium. And in fact, the specific one for that is over here under pericarditis, Dressler syndrome, which usually shows up a few weeks after the fact. And it's the immune system reacting to the pericardium due to this over-inflammatory reaction of dead myocardial tissue and proteins that have been released. And the immune system reacts to that now and is more antigenic and can affect the pericardium. And we'll talk more about that in another lecture. Okay. Lastly, this is the case question I want you guys to take a look at. All right. It has a few questions for you guys to follow up, which we will discuss in person. So good luck.